Buenos días, muchas gracias a todos por estar con nosotros esta mañana. Tenemos el cuidado y el honor de contar con la presencia de la mujer. Ella es profesora de la Universidad de Washington, Estados Unidos, y ha trabajado varias décadas en la prevención con la función perinatal, una de las autoras del Baby Sport, una investigación que tiene mucha evidencia y se en distintas poblaciones, y ella nos va a contar hoy un poco la trayectoria de su trabajo. Así que muchas gracias, Mimi. Ready to listen.
Okay, thank you. Welcome, everyone. I'm Mimi Lin, and I want to first thank Soledad for inviting me to come and speak with all of you. Is the sound okay? Sound is working? Can you all hear me okay?
Yeah.
Yes, wonderful. So I am a professor, clinical psychologist at George Washington University, and I've been there my entire academic life. So really most of my research has been from there, and from right before there, being at the University of California in San Francisco as an intern and as a postdoc. So I'm going to share with you a little bit about my journey in the prevention of perinatal depression.
Please talk a bit slower.
Oh, yes.
Thank you.
For the recording. Yes. Did it work? It's going? Perfectly. Okay. So here's what I'm going to do today. I'm going to give you an overview of perinatal depression, just a little bit of that, why prevention of perinatal depression is needed, and I'll talk a lot about the mothers and baby scores, which is something that I helped to develop in San Francisco. I'll talk a little bit about my current research in the area of perinatal depression, and then a little bit about the future directions of where prevention can go in this area. So starting off with, we think about the transition to parenthood in the social media as something that is very positive, that is happy, and it's very easy, yes? The mother can breastfeed her baby very easily. Baby is sleeping very, very well. Everything is wonderful. Unfortunately, this might be more the reality, right? Where women are more likely to become depressed, anxious, sad. Motherhood is not very easy. Breastfeeding may also not be very easy. Not sleeping. And also this affects the entire family. And fathers are also affected, which is an area that more people are starting to do research. So why focus on this particular area? So we know that mood and anxiety disorders during pregnancy and the first 12 months postpartum, this perinatal depression, are the most common complications of pregnancy and childbirth. And historically, people have not talked about this a lot. But it is very common. In terms of depression, which is what most people are focusing on, or in terms of research, affects about 1 in 5 women. Screening rates by professionals are very, very low. Anywhere about 20 to 25% of people are screened. And most of these are in North America rates, essentially. And even if they are screened, very few people get access to help. So they don't get treatment during this time. And really only about 10 to 15% of those with major depression actually become depressed. So, common problem, and it also affects the entire family. So a lot of this work has been in the area of perinatal depression, a little bit more in anxiety, And what we find, and people are also looking at this, is that suicide is becoming very, very common. And suicide is the leading cause of death during this perinatal period. Perinatal depression affects everyone in the family, really affects the mother-child dyad, including attachment and parenting issues. It worsens the whole family functioning. So fathers are also affected when the mother is depressed. And then in terms of the babies themselves, there are a lot of different complications, starting a pregnancy, birth and delivery. Some mothers may also have some birth trauma, which also is associated with depression. And once the baby also has some negative developmental delays, whether it's cognitive, whether it's developmental. And some research has found that this is very long lasting, so that it could be when the mother is depressed, the baby can continue to have problems up until adolescence. So it's a long-term problem, and that's why I think we're focusing on this area of perinatal mental health. Also, there are high economic costs for society, so economists are starting to look at what is the cost of not treating depression during this particular period of time. And in the US, the annual cost of the annual lifetime cost of this is estimated to be almost $46 billion. So there's also not only a psychological cost, but also an economic cost for doing this. So for all these reasons, we're thinking, is prevention a possible solution to address the economic costs and the psychological costs of a person, a family having perinatal depression or perinatal mood and anxieties? So my answer is yes, and that's what I'm going to try to convince you to be able to think about this and to do this. This graph is from the World Health Organization. I don't know if you've seen it or not. And the idea here, it's my pointer. Okay, there you go. The idea here is talking about treatment. So, for example, on the left side with this downward spiral here, we all have sort of a negative mood sometimes, right, on a day-to-day basis. You come here, there's a lot of traffic. It's hard to come here, so you may become a bit more stressed. For some people, they become so depressed that they cross this particular threshold here, and they meet criteria for what we call clinical depression or major depression. So hopefully with good treatment, evidence-based treatment, the person will become better, right? Up to a point where they are no longer meeting criteria for depression. So this is talking about a treatment part. When we're talking about prevention, let's see this one, there we go. We're really, again, talking about people who are starting to have those downward spiral. What are those risk factors? What's happening for them to become at risk for becoming depressed? And what we want to do is to provide an intervention to prevent them from ever crossing that particular threshold so that they resume their normal life. Right? So this is, when we do prevention research, we're really trying to figure out what are the risk factors for people who are doing this downward spiral. But can we provide an intervention so that they feel better and never become clinically depressed? So we're looking at the incidence or the new rates of major depression. Questions? Make sense? Yes. So as we think about this then, what do we know in the US about interventions that can prevent major depression? So the US Preventive Services Task Force is sort of a national group of people, experts who get together, and they look at all of the research that's been done to see, are there interventions that are effective to prevent perinatal depression during this particular period of time. And so they did a big meta-analysis, 17 different studies to look at this, and this is their conclusion here, that counseling interventions such as cognitive behavioral therapy and interpersonal therapy are effective in preventing perinatal depression. So that's great. And in particular, people who benefit the most from doing this include women with a history of depression. So these are some of those risk factors. Current depressive symptoms or certain socioeconomic factors like being low income, young, or having a single parenthood would benefit. So here we're starting to look at who are the potential risk factors, who are the people who are more likely to become depressed, and can we really target these individuals who are more likely to benefit from a prevention intervention. And so when you look more at that particular article, what they did was they did a meta-analysis of 17 different counseling interventions, and they pulled together what the potential risk ratio is for doing that. And they saw that across these 17 counseling interventions, they were able to reduce the incidence of depression of about 39%, which is great. So it says that prevention works for this area. And in particular, they talked about 2 different programs that were very effective in reducing the risk for perinatal depression. One is this Reach Out, Stay Strong Essentials for New Mothers, the ROSE program. And in their research, this is IPT based, and I'll talk a little more about that. It yielded a reduction in the incidence. It could reduce about 50% of individuals becoming depressed. The other course is a course that I've been involved with. It's the Mothers and Babies course. And this yielded a reduction in about 53%. So really the main take-home message here is that we can prevent depression during the perinatal period with either a cognitive behavioral intervention or an interpersonal psychotherapy interventions. And we can reduce about 50% of the onset of it. So that half of the women get better and do not get depressed, which is great. So let me talk a little bit more about those 2 programs. I'll mention just a little bit about the ROSE program. This is originally a group educational intervention for pregnant women in community settings. And they've been able to expand this into about 90 different sites across the US that are seeing pregnant women. It's primarily interpersonal psychotherapy, so they focus on the transition to parenthood. So this motherhood is really hard. How do we help you to get more support during this period? Right? So helping to improve communication skills, helping to increase social support. Originally, it was either 4 or 8 sessions that were group-based in pregnancy, and then you have a 1 postpartum booster session that occurs. It's available in English and in Spanish. You get training to be able to do this. And one of the nice things to make this more sustainable is that it doesn't have to be delivered by a mental health care. So they're training nurses to be able to do this. They're training health educators or paraprofessionals to be able to do this. So if you're interested in this, I would look up the ROSE program, and Botnick and Jennifer Johnson are the people who are running this program right now. Then I'm going to spend a lot more time on the Mothers and Babies course. This is the work that I've been doing for the past 20 years or so. And the goal of the Mothers and Babies course is, again, prevention, trying to reduce the onset major depressive episodes by teaching women mood regulation skills and education about parenting and child development. And we're really focusing in particular for women who are at high risk for depression. And for us, that means people who have a history of depression as the risk factor, or if they have currently high symptom score. And also, I think being low income is part of that risk factor that we have been doing. So it's group-based. It's available both in English and in Spanish, and it's manualized in that there are a facilitator's manual version that you can learn about this, and then the participants themselves also have their own workbook that they go along. And at the end, I have a website that you can download all of this information. So it is based on cognitive behavioral therapy. I know some of you are clinical students. So the idea of cognitive therapy, which has a lot of evidence for treatment as well as prevention of different disorders and across a number of different populations. Okay. But the idea is that a person can become depressed or anxious, have poor mood regulation due to either having maladaptive thoughts, so negative thoughts, or sort of behaviors that are not very helpful. So a stressful situation might be something like the baby is crying all the time. So the baby cries all the time, the mother might have the thought of, I'm a bad mother. I can't make this baby stop. So she's trying to walk the baby around, she's not sleeping, and those thoughts, I'm a bad mother, I'm a failure, is certainly going to make her more depressed. Right? And because of those thoughts, maybe she's not paying attention to her mom, to the baby as much. Right? And that then makes her feel worse. So it's a bi-directional, cyclical relationship in doing this. And so what you're doing in CBT is either trying to change the thought or trying to change the behavior. So this is traditional CBT. One of the ways in which we have done this separately, and I was telling Sol about this with my mentor, Ricardo Munoz, who created the Mothers and Babies course along with me when I was an intern and postdoc in San Francisco. And one of the ways that we really adapted this for low-income populations is to think less about can we control the thoughts or the behaviors to more about this idea of managing your thoughts and your behaviors. So we talk about this as a reality management model. So the idea here is that we all have a reality, and our reality is comprised of two different parts. So we have our internal reality, which is really where our thoughts are. And that's the thoughts part of the CBT model. And then we also have our external reality, which is everything outside of us. So this is the people sitting in this room. This is how you were able to get here. This is your family, your neighborhood, everything that is outside of us. And that our internal reality and external reality are certainly related. How I think about my family, for example, is my internal reality affects my external reality. My internal reality, the thoughts that I have, I'm a bad mother, certainly affects how I feel. And if I'm not doing anything, I'm not sleeping, I'm not eating, that certainly affects how I feel too. That's part of my external reality. And so in the Mothers and Babies course, what we do is we teach women about this idea of how do we manage our reality to have the healthiest reality possible for ourselves as mothers, but also then to teach that to our babies. And so the Mothers and Babies course is divided into 3 different modules. So we have one module that is teaching about my internal reality, how my internal reality affects my mood. And then we have 2 parts of the external reality module, which is one about the activities that we can do usually by ourselves, our pleasant activities. So when you are happy, what do you like to do? Some people like yoga, some people like to dance, some people like to sing, right? So those are our pleasant activities. And when we're feeling down, when we're feeling depressed, we're not doing a lot of those. And so part of that module is to try to increase our pleasant activities so that we can feel better. And then the other module is talking about the relationships that we have with other people. Is my husband supportive during that particular period of time? Can I ask for help if I need to? So what is our level of social support? What is my relationship like with other people? And if I don't have enough, how can I get more help? So we really focus on communication, learning about communication, learning to get help, and learning to identify our social support. So those are the 3 different modules of the Mothers and Babies course. And so over time, we have worked with other collaborators, and this model, the Mothers and Babies course, has been adapted. So originally, it was just group-based. So getting groups of women together who are at high risk so that they can also provide them with support. And so you can see the same model. We have an introduction to the models. We can go into pleasant activities, thoughts, and contact with others. And then sometimes you have a graduation and you are done. So my colleague Darius Tandon at Northwestern University has also adapted this for delivering this one-on-one, because sometimes it's hard to get women together during the group, right? Or during COVID, when it was hard to get everybody together. So either you could do it online and Zoom formats for the groups, or in his case, we have in the US home visiting programs, so that they are home visitors who can come and help during pregnancy to check in on women who have high risk factors. So maybe low income, for example, immigrant population, and then they also come during the postpartum period to provide additional services. So these are maybe half-hour visits that they could do every few weeks during this time. And so what he did was he incorporated short versions of the Mothers and Babies course, 15-minute activities to be able to do that. So let's teach about, have you gone for a walk this past week? You know, when you're feeling down, what is that like to be able to do that? So these are things that can be delivered one-on-one by these home visitors into their homes, trying to make this more accessible and more sustainable. And so if you go to his website, you can download these particular versions to be able to do that. I think the other thing that Darius did that we've incorporated is also to include some mindfulness activities within these sessions. So, you know, when you're feeling down, how can you make your, you know, what are some of the tools that you can make yourself feel better? Maybe some deep breathing exercises. So for the moment, just focus on the present and help yourself feel better. So there are some mindfulness exercises that are also incorporated. My colleague Lynn Barrera was at Palo Alto University. She also worked with Ricardo Munoz. And what she did was develop an online course for both mental health professionals who want to learn about this course on their own, and also for women who can do this by themselves. And so this is, you know, this tries to remove the barriers of, I have to come somewhere at 2 o'clock on a Tuesday afternoon to do this. I can do this at any time, right? I can log on at any time, and it's at your own pace, at your own self, to be able to do that. So there's an English version, and then there is also a Spanish version of this that they can do by themselves. So if you go to this website, you can log on, and also health professionals can log on to do that. Lynn Barrera also created a baby text version of the Mothers and Babies course. And this is to start to address the issue of everyone having a smartphone, but maybe they don't have enough data on their smartphone to be able to download an app. So she partnered with a community center in California to be able to deliver this just as an adjunct service for women. And you can see it's just getting a text. It's completely, fully automated based on this. And when she was doing this, I would say maybe 2 or 3 years ago, they had the introduction at first on Zoom, so everyone can get to know each other. And then they have the text that they can do on their own. And at the end, they have a graduation version of this on Zoom, just to have that social connection to be able to do that. But the idea is they're just sending very short messages and having people respond to those messages. Again, based on this cognitive behavioral therapy, based on that work. So you can see everybody has stress. Remember to keep track of your mood, and then a very short mindfulness exercise. So they're delivered at different times during the week, and this program can track how many people are responding, how are they responding, but there is no live person on the other end of it. Different version of being able to do that. Most recently, Adam Lukowitz, who is at Brown University, has created a Mothers and Babies smartphone app. So these now are for people who have a smartphone, and he is testing this out right now and trying to get additional funds to make it more fancy, because that's what the women who were doing this originally was saying. I think there's 10 to 20,000 mental health apps that are out there. So there's a lot of competition for this, right? But this is, I think what he's trying to do is to argue that we want to develop apps that are based on the evidence, that have evidence base, to make sure that it works. And so trying to really test this out. So again, you can see there's a mood scale that is part of the app, and it's part of every intervention, every session that we do in the Mothers and Babies course. On a scale of 1 to 9, how is your mood? 1 being the absolute worst mood. This might be the day that you lost somebody, there's a death in the family. 5 being average mood, and 9 being, the best mood ever. You winning the lottery, right? Maybe the day that you got married. So maybe for most of us, we're not at a 1, we're not at a 9, but maybe we're somewhere between 2 and 8. So this is a good way of just helping our participants just understand more about their mood. And then you add to that over time in terms of, if you're at a 3, what are some pleasant activities that you can do to try to improve your mood? Or who can you go with to get help? Maybe I'll call my friend because she makes me feel better over time, right? Or what kind of thoughts am I having when I'm at a 3? Oh, I'm not the best mother. I'm kind of a failure, 2 or 3, but maybe I can do something to make myself feel better. I'm trying my best is the other thought, and that might help my mood to go up 1 more. So he's adapted this using, again, these different modules to be able to do this. And one of the adaptations is to encourage people to do their homework here. So on the middle side, you could get a medal if you are able to do your homework every single day of that week. Again, you can see on the right side, my right side, this idea of, again, the inner and outer reality, and teaching them about this and how do I then modify or manage my reality. So that's all the work that's been done in the US. We've also, and Darius Tandon and I have done some international adaptations of this work over time. And why is this important? This is important because Depression doesn't only occur in the US, it occurs all over the world. And there are different rates, as you can see here, over time and in different countries. And some of the different variations of rates may be due to how it's measured. Is it measured using a diagnostic interview? Is it measured using, for example, a screening scale? So I'm going to give a shout out here to one of your colleagues' work here in Chile, and in terms of what we know here in Chile. And so your work with your colleagues have found really high rates, in particular of both depression as well as anxiety during this perinatal period from pregnancy to 6 months postpartum. And so again, what are some of the opportunities here for you to think about in terms of integrating prevention as part of this work to hopefully decrease some of these rates over time? So when we think about cultural adaptation and going into any new setting, any new country, this was a very short version and model of how we thought about adapting different interventions. Our Mothers and Babies course for different countries is to think about what's the need there, right? Gathering some of that information, figuring out if we have this existing Mothers and Babies course, does the context of this make sense for your particular community or not? The importance of gathering data and gathering information once you deliver that particular adapted intervention to really see if it works or it doesn't work. So we've done this in a number of different settings and countries. So there are different variations of the Mothers and Babies course in terms of dosage. So how many sessions can we deliver the Mothers and Babies course in? So the original version was 12 sessions, and that was both for, and the idea originally was to try to do everything during pregnancy. And then we realized we didn't have enough time. So it got shortened to about 8 sessions. And I think 8 sessions is about the right number. Ideally to try to do it during pregnancy and then have some booster sessions in the postpartum. But we've also shortened it to about 4 sessions to do it as a universal intervention. So the idea here is that everybody can probably benefit from learning some of these mood management skills, some behavior activation. So we've gotten it down to 4. We've done this in different settings. So in an OB setting, obstetric setting, a community health center to be able to do this. We've done this, and I'll show you some work in Africa where it's literally in the villages on the ground. That's very different. And then facilitators. So I mentioned it doesn't have to be done by a mental health counselor. It could be done by non-mental health or paraprofessionals. And that might then increase the reach of the dissemination over time. And countries, there are a number of different adapted versions of this, including one for Greece, one for Iran, different versions that I'll give you a website that you can look through for that. I'll share a little bit of my work that I've done in sub-Saharan Africa since about 2016. And this is in collaboration with Catholic Relief Services, which is a large international nonprofit humanitarian agency. And what they have been doing, and the work that I focus on, is in the area of early childhood development. So really focusing on the area of pregnancy up to for mothers with children 3 years of age or less. So those are kind of the critical period of time in terms of growth for children in this area. And they focus a lot on things like father involvement, nutrition, increasing access to health care. And what they didn't have at the time was talking about mental health. And they also found in their baseline data about 30 to 40% of people were having high risk for distress. And so, so what we did was we integrated some of this idea of the reality management model into what we call an integrated mothers and babies course so that it could be delivered for their early childhood development. So we took things from that program, such as when people are depressed, they have difficulty breastfeeding. They're not likely to go to the health center to get their prenatal care. They're likely to be isolated. So we took some of that and put it into the mothers and babies course and really talked about, you know, when you're depressed, this is what is happening. How can you increase support, for example, in these different groups? So we started this work originally in Kenya and in Tanzania, about 12 sessions that were done, and they had a mental health counselor deliver this along with a community health worker who did the early childhood development program. Then we realized they weren't talking to one another, and so over time, we've switched it so that it's only one person who delivers this information at a time, and then they can continue with their curriculum afterwards to make sense. So I did some of the training, we did a lot of adaptation of this work, and it's a low literacy population. So, and primarily a lot more oral, depending on the different dialects. So we did a lot of adaptations, including our mood scale that is much more visual, as you can see here. I'll show you in the early version, 2017, we didn't have any of this, and people were very adaptive, right, to be able to do this. And this is a self-rated, self-produced mood scale that was done in the villages. This is a hard thing to see, but it's one of my favorite things where they posted that mood scale onto a table, tied it around a tree, and then there are women sitting around here reporting and posting on their mood scale. So all this to say is that this particular intervention can be easily adapted to different populations over time. There's been a really good randomized controlled trial that was done by some individuals at Duke University that was done with this in Ghana, in Kenya. And what they found was that qualitatively, the Mothers and Babies course, the integrated one, was highly satisfying and really fun to do. But that overall, there was not an impact in terms of reductions of depression for women who participated in the integrated Mothers and Babies course in Ghana or in Kenya. But what they did find was that it worked mostly for individuals who were at higher risk for depression. So moderate depressive symptoms, they were more likely to attend the intervention, lower education status, but they had more children, and they had no experience with physical or sexual intimate partner violence. So I think what this showed us is that this Mothers and Babies course was not for everyone. It really is important to identify who is your high risk group for being able to do this. And so with this information, and really thinking a little bit more about sustainability, what we've done over time and what I'm doing right now is working with sisters who are in Catholic congregations in different parts of these different countries because they're more likely to be there. So we're training them to become the master trainers of the Mothers and Babies course. They in turn train community health workers, community health promoters in these different villages to deliver the intervention, and they provide the supervision of these community health workers and thereby really increasing the reach of these people over time. So right now we're in Ghana, Kenya, Malawi, and Zambia and doing this work. And they have also started to do this work with fathers, but using, and they sort of took this on their own, where they saw a need for fathers, and so they were using our materials for the mothers for the fathers. And then the fathers said, oh, but you don't have any pictures of us. Yes, we don't, because it wasn't intended for you, right? And so right now we're in the process of working and developing an integrated fathers and babies course, starting with 4 sessions that can be delivered for everybody, the idea of a universal part, and then thinking about if they're still at high risk based on the EPDS, we might then deliver a 13-session version. That's the plan anyhow, but that's where we are with that. Okay, so I'm gonna run real quick, thinking about some other research that I'm doing right now. So prevention is great, and I've been an advocate of that, but prevention is only one part, right, of the idea of thinking about how we can help everyone across the levels of psychiatric severity. So for some people who are not depressed, but at high risk, prevention may work. But when they are clinically depressed, we do need treatment. And then we also may need continuation of care over time. So relapse prevention, maintenance care is going to be important. So prevention is only one part of this integrated mental health care. And so this work that I currently am doing right now with Catherine Douglas at Children's National Hospital in DC is focusing specifically on low-income Black and African-American mothers. And we're trying to address multiple components of care for this particular high-risk community. And so it's a randomized controlled trial recruiting low-income Black mothers to this. And then everybody who is in the intervention arm gets a patient navigator. And this person will be with them throughout the entire pregnancy and postpartum journey to address the social determinants of health. Housing, food, nutrition issues, domestic violence, some of those have been the most common parts. And then in addition to that, based on a diagnostic interview, they're invited to participate in a prevention group if they're not meeting criteria for depression or anxiety, or if they are, they can get individual treatment, primarily CBC-based, adapted for this group. And then they also have the option and the preference to join a peer-led support group that is virtual to get some of that support piece. And so we're recruiting about 700 women to try to see which of these different components are most likely to improve maternal and infant outcomes over time. The other area that is a newer area of study for me is in the area of suicide. And we're doing a mixed method study for this reason. One is that suicide and overdose are the leading causes of death during the perinatal period. So really, really high, but there are no programs at all that are specifically geared for preventing or treating perinatal suicidality. So what we're hoping is, in partnership with Jennifer Keller, who's an obstetrician, is to do a 2-part study to understand more about this area of suicide during the perinatal period. So in our first part, we're doing we're looking at medical records in a large OB setting to look at the prevalence and risk and protective factors of perinatal suicidality. And our sample is about 4,000 people during this period, and our prevalence rate is about 4% is what we found for suicide. This is suicidal ideation, so thoughts of suicide based on the EPDS item number 10. The other part is a qualitative study that we are doing in which we are recruiting for an online survey to look at the emotional experiences and intervention preferences of individuals who have suicide. And so we're just trying to understand more about these different experiences and asking about if they had treatment, what was that like? If they would like to develop a treatment or an intervention, what would that be like? So gathering their intervention preferences. So we're still in the process of doing this. Unfortunately, right now it's in English, but this might be a good area to think about collaboration to get more Spanish-speaking populations. And this is one of our early findings here that I wanted to share with you. We're still in the middle of collecting this. My relationship with my partner changed drastically after I became pregnant. We argued more and I felt more distant from them. The strain on our relationship made me feel isolated and unloved. The emotional pain was so intense that I started to consider suicide as a way out. So really, really important, and we're just at the beginning of trying to understand this one. So a couple things for future directions. I'm going to point you to an article that I wrote with Ricardo Munoz on this in celebration of the International Marseille Society for Perinatal Mental Health. And it's really talking about the history of perinatal depression prevention work on this. Talks about both the ROSAs as well as the mothers and babies course. And it has as a supplemental table all of the different versions of work and the different translations of this that can be done over time. And what we really wrote is, that was 40 years that the Perinatal Mental Health Society has done. What about the next 40 years in thinking about perinatal mental health and the prevention work for this? So I encourage you to look at this. I'll just highlight a couple of things. One is, ideally, as we do more work in this area, how can we make this more accessible and more free for everyone over time? And can we continue to try to reduce the incidence of perinatal depression to the minimum possible? And how can we do this in the different settings in which we work in, so that ideally we can enjoy a world without perinatal depression, so that it really can improve the lives of the mothers, fathers, and their families over time. So including routine evidence-based interventions to be able to do that, screening, and thinking more about digital aspects of interventions. So this was going backwards, but it's fine. Making community and societal interventions that are universally available. So I will stop there. This is my contact information as well as my website that you can get additional information. And I'll take any questions that you might have. That was a lot of information. Katie, please.
Maybe you can talk a little more about your study at swimming with the 700.
Yes.
You talked about 4 options, I think.
Yes, 3 different options.
So
yeah,
people get one of those.
they can get any of those. They can get anyone who is in the intervention arm. What we're trying to do is address all of the different problems that low-income women can have.
And the patient navigation, is that is that living their lives, like understanding how it goes, or they do some?
They do, yeah, they do. So, yeah, what we do is we call it like a wellness assessment. So we're really just trying to understand, are there any areas of your life that we might be able to help? So things like social support. Do you feel like you have enough social support? Do you have any housing issues? Housing is a big problem that we can't solve, but we can help to make appropriate referrals. Are there any legal problems that you have? And I think the other challenging one is domestic violence. Are you in a safe relationship? So sometimes what we found is that if that patient navigation, we can't address those issues, they're not ready for mental health interventions, and they're not ready for support groups. Or some of them just want the support groups, they're not interested in the therapy. So with a large sample, we could look at different components and see what works the best. And I will say the group part has not worked at all. It's really, really hard to get groups together during this time. And with COVID, everybody wants to be online, and it's much harder, I think, to make that support in that connection. Yes.
Okay, well, first of all, thank you very much. And regardless, in regards of the same project,
Yes.
are you only looking at Black African American or
Yes.
like Latin population?
just
Have you
Latin.
translated it
Yeah.
to Spanish?
Not yet.
Not
This
yet?
one in particular, because of the request for the funding was specifically for Black women. So that's focus.
Yeah, and in the same line of translation, when you refer to the app,
Yeah.
that the app has been translated to Spanish?
Good question. I don't think so. I think right now it's only in English.
And it's available for
Right now it's only available as a research study.
yeah, not like Apple Store.
Not yet.
Not yet.
I think maybe in a couple of years when it gets yeah. Yeah, I think yeah, and Adam is actually an obstetrician who really wants to increase this work, and that is one of the ways we're thinking about it. He's thinking about it is, can they integrate it for insurance companies so that it becomes part of a service that anyone who has that insurance, health insurance, can get access to that. And so it may increase access to one population, and maybe not as much for the others. We don't know. It's like, yeah, it really is.
Yeah.
Complex. Hello. Well, first of all, thank you for this time. And I want to ask you, based on the annotation of that you made of the mothers and babies, were you like allowing it to be done in groups or individually? Did you make a comparison of the results of the symptoms of depression between these two forms of work?
At the same time, right? In terms of that, we have not. We've really tested this more in groups. Daria Camden has tested this more in individual, but I don't think we've been able to do both. Yeah.
And do you think that it is better in order to reduce the symptoms to do it individually or in groups, considering that women can make connections, but some women are not ready to do those connections?
Yeah, I think that's a great question. I would say it really depends on your context and your setting, right? And so if so I know here you're very much more collectivist. So the whole idea of the support piece is so much more important for that. So I will say I think it depends on your particular context. And one way to do that might be to do a focus group at the beginning before you start and get some women together and talk about, if we were going to do this here, which parts would you like? Would you want to do it individually, but maybe also have that hybrid? So for the baby tests, where at the beginning, everyone can come together. You could do it separately, but then continue later. In Spain, when we did this, and my colleague did this, they did it in person, but when the group ended, she did 6 sessions. When the group ended, everybody still shared their WhatsApp together, and they continued that group on their own. So they shared their daily stories, their pictures, their struggles, but that was something that was organic, and they continued that part on their own. So it's another way, right? Another way of maintaining that connection. Thank you very much.
So I was wondering about your study in Africa and how you trained nuns.
Sisters. Yeah, sisters.
Sisters would be mentors of this community
Health workers.
and I think it's a very clever model. And conference a while ago, there was someone talking about this this model in Brazil, where there have very few professionals and the population is huge. They were training community workers to deliver simple interventions. And I was wondering, how was the training for these sisters? How did you, what kind of complications did you have to do so they were able to supervise them for this health?
Yeah, they, so some of that, you know, when you do some of these collaborations, some of that is outside your control. It's like, who shows up,
Yeah.
right? Like they, you know, so we provide some guidance initially in terms of, one is that you are stationed in that setting and you're likely to be there for a long time. Ideally, you have some kind of a professional background. Some of them were also nurses, some were psychologists, some were sort of health educators themselves. And so they all came together. But pre-COVID, I would go to one of these countries and they would all come together and we do this in 5 days. So it's very intense. And a lot of them didn't have this background. So you kind of start from zero. You start from, what is perinatal depression? Why is this important, right? Like why are we focusing on this? And so you get that buy-in for them. And most of the times they're great. I mean, I think they're actually a lot, they follow the directions a little bit more than when I've had like just mental health counselors who they think they know better and they want to do their own thing. So they're actually very dynamic and very appreciative of this over time. But there's still like a different variations. So that we do a lot of the training, but we do a lot of practice together, just so that I could see, just so that they could sort of say, reality management, in or out, like what does that mean? And the thoughts is always the hardest part. So we spend a lot of time in that. So we do practice within the training, and then we go actually in the field as part of the training into a local village, and they get a chance to do like one mini mock session so that they can see what is this like. We come back, we do the debrief, then we really talk about after the training, the continuation. So I still provide sort of monthly or bi-monthly supervision where I meet with them so that once they're in the field, they fill out fidelity forms, we look at the fidelity forms, and they provide reports back. And that's a way of trying to continue to make sure that they can do this with fidelity. One time we went to Kenya and then asked the community health workers who had been doing this to give their own testimonials about this. And I think that the good thing about this is that we can all use these skills ourselves, right? So the relaxation, the doing more pleasant activities, so that they felt like they could also benefit from this. And when they can, then they're likely to be able to share that experience more with the others. So when I talked about things being outside of my control, like the fathers and babies, they used our materials and just said, here's 20 fathers, they want to do this, and they did it. We're like, okay, so now what, right? And so now that's why we're taking a step back to really be able to develop those materials. And we share it with them. Do you like this picture? Does this picture represent the different, mood scales? And so that's part of the body. But they are just incredible. They're really, some of the best people I've trained being able to do this. Yeah.
I was wondering as well about the fidelity, because you train these people for 5 days or so,
Yes.
and they are supposed to supervise all this health community.
Yes. In a different language.
Exactly.
Yes,
So
yeah.
how do you check that they are doing enough of the intervention to still be called the mothers and babies
Exactly.
before it turns into something else?
I think that's a great question, Phil. So the fidelity forms are one way, and we train them to fill out those forms. And at the beginning, 1 to 10, 10 being the best, 1 being not a good at all. Everything was a 10. Right?
Yeah.
9 and 10, even in session 1. And so we had to sort of take a step back and say, hey, it's okay, it's more, or tell me how you taught this, and so I could get a sense of that. But yeah, I think that's the part that I kind of, pre-COVID, we could go into field business. Actually, we go into the field with them and see some sessions, some real sessions, and then kind of see, oh, what worked or what didn't work, and give like real time feedback. Post-COVID, it's all online, much harder. Maybe one more question, maybe we're out of time. Yes.
Thank you for being here and sorry for my English.
It's
a really what has it been to adapt the curve for fathers? And how have you addressed cultural differences, especially in patriarchal contexts, to make it more inclusive and
Ooh, great question. That's a great question. So the father's piece. So Darius Tandon actually has a fathers and babies book that was already developed for U.S. American kids. So we were able to look at that as a starting point to help. One of the things that's really different from for this Africa adaptation is the stressors. And so we got a lot of feedback. Because they ran this by themselves, they then went back to us and said, here's what they said of what the stressors were. Substance abuse, there are lots of alcohol. In those societies, the fathers will take a job in the city. So they actually don't have a lot of contacts with their kids for maybe months at a time. And during this time, babies change so much, right? So that connection is really hard. So we start off, and we talk a lot about what are those stressors that the fathers face. And those are the ones that we're adding to this new version of it. So the substance piece is big, the isolation is big. Knowing about mental health and mental health stigma is even higher for the fathers and the mothers. And so we're taking it very slowly. So we talk about stressors that can lead to depression in fathers. What does depression look like in fathers? And getting their sense of that. Isolation, not being able to take care of the baby, and the finance is really big. So we incorporate those in for that. The patriarchal piece is hard for when you talk about communication, right? And how do you talk about this, when we say in a clear, direct way, where you may not be able to do that. So within the groups, and this is for the moms. So with the fathers, we're still figuring that out for this new parts of it. And so what I'm hoping is we'll get the text done. We'll go back and we'll talk to the sisters about this to get their feedback. And then they're going to go in the field and do it. And then ask for feedback from the fathers after that. So it's going to be a multi-step process. And then we'll probably have to go back and make more changes to the intervention itself. So it's a multi-step process. So don't do this while you're a graduate student. Right? You want to do this when many years later into your career.
Thank you very much. Y muchísimas gracias a ustedes por su mañana y tienen una compañía.